So first of all, it's a great honor for us in the Red Cross School for you to be here. It has been an immense pleasure to meet you all and people that I only knew by name and admired at distance to finally know you and admire you even more because you are also friendly, and yes, we all feel like this is a family, so I'm learning a lot even before this day, so thank you for that. So, picking up a little bit what was discussed in this morning about the differences between what podiatrists do and mainly on teams or without teams, one of the things that we found out is that within countries you already have a lot of variability. So I think that one of the struggles that we have, it's not only between countries, but also for us to clean the house and also to within the country to try to have any type of standardization. The other question is about the autonomy. I believe that even if we are in a team, we have autonomy. It's like a football player. You decide if you shoot or if you pass. You have full autonomy if you are embedded in a team. So the question is the amount of people that you need to work with. So, first of all, I am a podiatrist since 2005. I've worked, and my passion was always diabetic foot, so I directly started working on a multidisciplinary team, so this is a reality that I know very well. And the other thing was that once I started working, I found that we still had so much to learn, and so that is why I then changed more to an academic field, and so I did my PhD and started doing more research and also teaching, and so now I'm a little bit far away from the clinic, but trying to help people to do their clinic better. The other thing that I would like to say is that I'm a member of the WGDF, so I will say this is the best organization just because I'm in it, and that's it. So I will talk a little bit, but a small part about diabetic foot and the Portugal reality, what is the history behind it, and also the questions that we have with so much variability on the role of the podiatrists within the different structures that we know within the diabetic foot. Also, I'd like to talk to you about the POINT project, and it's good to have here Mike that worked on this magnificent effort so that people had something to work with, to know what was the minimal on the different settings and at least to have a list of things that we should follow and strive to teach and to do in each of the settings. And the other was a really small survey that we did in an informal group, just for you to have an idea of how much things are so different depending on where you're working and where. So, because one of the struggles that we have is that we have a good history about diabetes care and diabetic foot care. We had the first association of diabetes in the world. So in 1926, we created an association to protect people with diabetes that did not have a lot of resources. We had our first diabetic foot clinic in Porto, again, the best place to be because I'm from Porto in the north, so that is why. And this clinic was created only 7 years after of the King's College. So we are not that far, not that slow. So why is such a struggle to have podiatry following the same routes, having us such an important role? And the other thing is the most recent national guidelines, it's not the translation of the WGDF, but from the Ministry of Health, is from 2011. We have another one ready to come out since 2015, but it's just in a drawer somewhere that we cannot make it to the sunlight. So this is what we know so far. And for example, one of the things that I would like to highlight is that in this guideline, on this norm of what we should do and organize care in Portugal from 2011, it says that in all of the levels that you need to have a professional that is trained on podiatry without a definition of what this means. So if you do a small course and you have any type of profession as base, you can do this. You can be on this level and this is accepted. So this is one of the first things that we are trying to change, and on this new guideline this will change, and at least in some levels you need to have a podiatrist and not someone who's train in podiatry, whatever that means. This is a good news. We have a national questionnaire, and we started with, on the National Health Service, to have only 72% of people with the food screening, and now it has passed to 81%, which is really good, and this is changing, so people are looking more at the feet, or at least to make a registry about it, which is really nice. But this does not mean that the screening is done by a podiatrist. It's just that people are looking at feet and to do this categorization. The other reality that we have is that from the data that we have, the rate of major amputation is declining, although Portugal now it's rising a little bit again. So we're not very good in Europe, sorry. But we have been diminishing this, and one of the things that is really clear is that if you look to the rates of amputation between regions, the north is always the one that has the lower level, for two main reasons. This is where the first school of podiatry is, and also it's the place where you have more hospitals with podiatrists and multidisciplinary teams. So we also have, like Alfred said to this morning, is that we have evidence that having multidisciplinary teams work, that having podiatrists work, but it's still a struggle. Then the other question is, what should be our role? Because you can pass from a reality from now the toe and flow, you need a podiatrist and a vascular surgeon, and the rest is collaborators, and you decide on this binomial structure what to do. Then you have the podiatrist as the gatekeeper, but then wound care nurse or podiatrist. So yeah, in some places one, in some places the other, but he is the first one to see a patient and then to decide what is the mobility within that team. Then you can have a podiatrist as a coordinator or a leader. Then you can have a podiatrist as an integrated member, and then you have a podiatrist as a luxury. That's it. With small schedules, with small availability, with small access to things, and some patients, if they are lucky, they can see one. So we have this type of variability, not also between countries, but also within Portugal. So that is why I would like to talk to you about, again, from the Point project, because this is something that not all of us know, and this is essential for people that work on diabetic foot. So please look at this. This is an initiative that works together with two good federations, and they try to discuss what is the minimal skills and what we should teach and what we should do. And at least we have a ground basis to work on, at least about diabetic foot. So this is something that I tell my students to read. Okay, I put it there and say it is important. So I try to do as much as publicity to this project as I can. On this, I don't have any disclaimer. I had nothing to do with it. I just like it. So what we have done, just for you to have an idea, and for us it was really interesting, that we made a sampling snowball on an informal group only during 1 week, just for us to have a glimpse of what is this structure. And we made the online survey. We requested podiatrists that work at least in one diabetic foot team independently of the level they worked with, and then we just make all the questions that we thought you will give us completely different responses. And as we were expecting, see the ratio between the regions. You have 10 that are from the north, 4 from Lisbon, and then some people scatter on the rest of the country. And this is the reality also of the availability not only on private but also on public places. So most of us worked on hospitals, but then you have people that work specifically with people with diabetic foot on private clinics and mainly on private hospitals or other type of agreements. We had one colleague that worked on primary care, and this is a really important one because it is in the north on a very near to Spain region, and usually low income, low access to care. And so this colleague goes to and covers a really good region. So this is a nice effort. And then you have people that work in a nursing home and people that work also on other types of places, and mainly on private, public, and some in both types of institutions. So what we found out is that almost 1/3 of them worked with diabetic patients, but without a multidisciplinary team. So only with outpatient appointments and without being integrated in a group. But most of us work in an hybrid scenario, meaning we belong to a team, but we have specific appointments for outpatients. So we can do both at the same time. Most of us cooperate with nurses. We almost every time have a nurse within the team or working along with us, endocrinologists and physical rehabilitation doctors. But one of the things that I would like to highlight is that mental health is really important, as we have been discussing, but we only had less than 1/3 of people having a psychologist in their team. So if we detect mental health problems or symptoms, usually we don't have no one to send, because psychologists have also problems in being integrated in the public health system. So this is also another struggle that we have. Most of us can perform independent podiatry appointments, as I said, mainly in outpatient, so full autonomy again, even if we are embedded in teams. One of the struggles that we have is, how do people send us patients? Can they send directly to podiatrists? Usually no. Usually they send to the director of the department or to a specific person in the department that then evaluate and send it to us. And most rarely they can send directly to podiatry, but that is a rare scenario. Usually you need to send to another person to send it to us, which is a little bit of nonsense, but it is what it is. The other question is, who can send it to us? Most of us can see patients by other services or departments of the same institution. You can see there that half of us can receive directly to podiatry, but most of us cannot. And, for example, it's really less represented to be able to receive patients from other institutions. So usually it's more closed mobility of patients within an hospital or an institution, and not that much from specifically from other places, depending on the scenarios. And usually you send to one person that sends to us. We have a good representation of all levels of care and complexity, so mainly we are in the most complex one, so level 2 and level 3, which is a good one, but then we are not usually on the front on the primary care on low-risk patients. That is still not very common. Most of us use, or at least all of us use the Sams-Weinstein monofilament for neuropathy, some of us the tuning fork and or reflex hammer, but only 2% uses other more advanced tools. And as we've been discussing today in the morning, we should do more PAD screening. And 9 of the 17 use the Doppler. 4, they do ABI, 2 dynamometer, 4 uses mainly other type of measurements, and 1 does not use it at all. It does not perform this, and 7 say that they use, but it's not that much. So then what are the type of patients that we receive in the daily basis? Well, we have a lot of spreading, but we can see that usually we cover them all, because I said that we mostly worked on type 2 and type 3, so how can this be? Because they are not podiatrists in primary care. So if they cannot treat them, even if it's not a patient that should go to an hospital, they send them anyway, because they don't know what to do with it. And so that is why this is a little bit of nonsense, but we receive patients from all types of risk levels on institutions of high risk level. Then 88% can treat and conduct follow-up of pre-ulcerative lesions. 77% in fact treat ulcerative lesions. If not, it is the nurses that do this. And 47% state that canteen treats feet with infection. So if you have an ulcerated infection, then a podiatrist usually cannot touch directly on the wound. All of us do digital silicone orthosis, but for example, 3 of us do not do and don't have access to it. 3 can prescribe and perform the molds, but then it's done in another institution. And most of us, luckily, are responsible for all the process and for making them. So you can see we are all over the place. All can perform offloading using foam, but only 3 report doing casts. And all can advise and prescribe therapeutic footwear, but not all the institutions can help pay for that. 4 of us participate of the 17 in educational sessions in group organized by the department, and we ask what are the difficulties that we feel on our clinics, and most of them reported we don't have the same registry and access to information as the other professionals. Sometimes we are doing things on paper when people are doing on electronic health records. Still, we don't have access to what the other doctors say. And so we are very limited on access to information. Access to specialized material and education, sharing complex cases in multidisciplinary meetings, because, again, I know some of the realities that they go and see patients that are hospitalized, and the podiatrist is there saying what should be done all the time, and some of the settings that you are working completely alone, and to discuss this with another professional as the teamwork that we should have, it's difficult. So again, a total spread. And the question again is, people don't know what we do. So they don't send, they don't know what we can do, and so they do not allow us to do some of the things because they think that we are not capable of them. And this is the hard work that everywhere, everyone needs to do. So there is a great variability on everything, and this is only within one country. So I really congratulate you for all the hard work that you have been doing to try to make this a little bit standardized and to improve the image that people have from the podiatrists and what we do, because if not, we will never be able to improve our autonomy and access to materials and services and access to information. And so I believe that the POINT project is a good foundation to it, and at least to have something to show and to explain to people, but we need to disseminate that even more within countries, and at least to have translations from it, for example, to implement and to be able to get to people on board of our project, that is a podiatrist to be able to do whatever he knows to do. So thanks to all the people that helped doing this work, and that are our informal network, and we are always changing ideas and learning from each other like we are in here today. And the other question is that I'm the coordinator of the podiatry course along with João, but I'm also now the coordinator of the Erasmus program in our school. So you have my email. If you want to collaborate, we also want to. So feel free to contact me, and thank you very much for your attention.